I am so glad that I can share my experiences on the ultrawide OCT in the surgical care of peripheral retinal diseases. My name is Jeon from South Korea. Let's assume that you met these patients in your clinic. What would you like to do? Would you like to do the laser photocoagulation or observation? What is your choice and what made you to do that? So this is the answer page. What is your score? Even for a trained rear surgeon, the decision is not always easy. You may do the laser for every patient with suspicious lesions, but unnecessary laser may cause a new retinal breaks in adjacent area. But now we have a solid proof for the laser photocoagulation with the ultrawide field OCT. This is especially useful for the eye doctors without vitreoretinal experiences, as it provides a clear base for a decision. So we need to say the most important role of ultrawide field OCT in surgical retina is the prevention of rhegmatogenous retinal detachment. A few years ago, I encountered several healthy young patients with multiple retinal breaks. I was curious about the cause of the multiple retinal breaks, so I took the ultrawide field angiography for these patients to find out the answer. On ultrawide field angiography, these patients showed peripheral leakages, especially in areas with retinal breaks. At first, I thought that it was a retinal vasculitis, but there was no evidence of inflammatory reactions in either vitreous or retina. So I've tried to get an OCT scan in these areas, but it was not easy to get an OCT image on peripheral retina. After a repetitive trial, I could get an image that suggests vitreoretinal traction in this patient. With the Silverstone, we are free to navigate the precise anatomic changes in peripheral retina. That includes a deep understanding of vitreoretinal interface diseases in peripheral retina. This patient had multiple retinal breaks and peripheral leakages on ultrawide field angiography. With the ultrawide field OCT scan, you can clearly see how and where the vitreous is attached on retina, and at the same time, you can compare with the ultrawide field fundus photography to understand how the vitreous traction made the hole and peripheral leakages. A key for a successful vitrectomy is to remove all the vitreoretinal traction. While it was easy to predict the vitreoretinal interface on macular, it was almost impossible to predict the vitreoretinal interface on peripheral retina before surgery. Have you ever seen these eyes that shows discrete margin of different retinal reflectivity? Do you have any idea about the cause of this finding? If you take the OCT scan of this area, you can find that the reflectivity of ellipsoid zone diminishes at the junction of the margin, and it seems like that the ellipsoid zone disruption are related to the vitreoretinal traction. As we all know, it is very tricky to get a good peripheral vitreoretinal interface image with previous OCTs. But with Silverstone, we can freely navigate the exact vitreoretinal interface with patients with DMDRL, which really helps when we plan vitrectomy. The presence of DMDRL usually means that there are abnormal vitreoretinal traction in this area, and this traction should be removed during the vitrectomy to prevent postoperative complications. One of the most challenging cases for vitrectomy is Stickler syndrome. If you are planning vitrectomy for a patient with Stickler syndrome, you need to prepare ensuckling, endolaser, cryotherapy, and finally, recurrence of detachment. This patient had family history of recurrent retinal detachment, and his father and sister lost their vision even after multiple vitrectomy and ensuckling. We did a whole exome sequencing and found that he had a mutation in his collagen II gene. The Silverstone shows what happens in his vitreoretinal interfaces. The vitreous is not separating with entire retina, rather it makes multiple traction on retina, resulting in retinal detachment in multiple places. This would be the very case where the preoperative ultrawide field OCT imaging on peripheral retina helps to plan a proper treatment. Let's move on to a normal, usual, rhegmatogenous retinal detachment patient. A 63-year-old male presented with a sudden visual loss on his left eye. What do we care most when we do the vitrectomy to repair rhegmatogenous retinal detachment? Yes, recurrence of the detachment and the proliferative vitreoretinopathy. An incomplete vitrectomy or any kind of remnant vitreous traction can cause the recurrent detachment and PVR. The Silverstone clearly shows the images of vitreous traction on mid-periphery, which should be removed during the vitrectomy. And the Silverstone can also reach to the far periphery where the retinal breaks exist. We can see the vitreous tractions both on anterior and posterior to the retinal breaks. This is the surgical video of the patient. I'm doing vitrectomy with 25 gauge Constellation system. After a total vitrectomy, vitreous traction was removed on both anterior and posterior side of retinal break, as we checked preoperatively with Silverstone. And then I checked the area where the vitreous traction was detected in mid-periphery. You can see that there was remnant posterior hyaloid membrane on this area even after removal of vitreous cortex. This is quite common to find remnant posterior hyaloid membrane after removal of vitreous cortex, and this is the major cause of recurrence after vitrectomy. He visited 1 week follow-up yesterday, and the retina was well attached. Another important disease that was related to the vitreoretinal phase is the epiretinal membrane. Epiretinal membrane is very common, that 70% of patients in their 70s have epiretinal membrane of various stage. Let's check this 57-year-old female patient. 3 years ago, she showed vitreomacular adhesion on disc and fovea. 1 year later, thin epiretinal membrane was detected, but the fovea was okay. And last month, she said that her vision of right eye was deteriorated, and I found that the epiretinal membrane was progressed to the stage where the retinoschisis had developed. So I planned vitrectomy with epiretinal removal. The preoperative Silverstone shows very wide extension of epiretinal membrane that reaches farther than major vascular arcade. This is the surgical video of the patient. The surgical field is a little bit blurred because she had the peripheral IOL in her eye. You can see the membrane is not easily detached from the retina, which was entirely expected with the preoperative OCT scan that showed retinoschisis. This membrane showed a particularly strong adhesion on the major vascular arcade, so I peeled the membrane within the major vascular arcade first. You can see a lot of bleeding spots after membrane peeling, which was also entirely predicted with preoperative OCT scan with retinoschisis, so we are not surprised by the bleeding. After the ERM removal within the major vascular arcade, I extended the peeling to the outside of the major vascular arcade. Because the remnant membrane is the major cause of recurrence, we need to make sure that we peel the membrane as large as we can. Today, she came for the POD 1-week follow-up and the membrane was successfully removed in entire retina. If you're a beginner in macular surgery, it is really important to know that not every membrane can be removed. I use Ingenuity 3D system for tricky membrane cases. That's why we have two separate images here. This membrane was suspected to have a strong adhesion with retina according to the preoperative OCT. As expected, bleeding from retinal surface was detected during the peeling, and you can see the retina is lifting as I peel the membrane, suggesting strong adhesion between retina and the membrane. We sometimes encounter a certain spot where membranes are not anatomically removable. I believe the migrated myeloglial cells are connecting the membrane with retina as if they were a non-separable tissue. This is quite predictable with preoperative OCT when it shows thick membrane and underneath tissues with retinoschisis-like lesions. Then it is better to stop peeling and remove remnant tissue with cutter at this point. The epiretinal proliferative lesion can be stayed, especially when there are little tissue on fovea. Membrane peeling was successful, but it would have been better if she took the surgery earlier in her ERN stage. The ultrawide-field OCT enables us to reach the perfection, especially in the mysterious far peripheral retina. I expect that we could find a lot of new knowledge with ultrawide-field OCT. Thank you very much.